Everyone, I'll be speaking on renal replacement therapy in liver failure patients. So I'll be covering under the following headings: introduction, indications of renal replacement therapy, choosing the modality of renal replacement therapy in liver failure, anticoagulation in CKRT, challenges with hemodialysis and peritoneal dialysis, role of intraoperative dialysis during liver transplant, then a little bit about albumin dialysis, and then concluding it. This is just a diagram to show when there's an initial insult, the liver decompensates and it manifests as a multi-system disease, which could lead to death or recovery. Not to go into the pathophysiology, but just to show that in ACLF there is multi-organ involvement involving the kidneys, the brain, heart, and the lungs. Now, principles of treatment of organ failure in ACLF, just to highlight the blue box, for the kidneys, we should firstly assess the assessment of the AKI severity using the modified KDIGO criteria, then treating it accordingly. Like if it is HRS, then we have to treat it accordingly, and then we have to define the RRT goal and do it as like a bridging to liver transplant. And the blue boxes, we should avoid nephrotoxic drugs like NSAIDs and avoid very early initiation of RRT. Acute kidney injury occurs in 20% of overall hospitalized cirrhotic patients and in 40% of those admitted to ICU. Ascites, elevated bilirubin, SBP, and use of aminoglycoside antibiotics have been previously identified as significant risk factors for renal failure in cirrhotic patients. The two most common cause of RRT in ICU for liver patients are ATN, acute tubular necrosis in the context of sepsis, followed by hypovolemic shock. Now, how do we classify AKI? Divide it in post-renal AKI, which is very less than 1%, pre-renal acute kidney injury, and intrarenal AKI. In pre-renal AKI constitutes about 66%. Then there is volume responsive AKI, and then there is HRS AKI, which constitutes about 35%, wherein the treatment goes about by starting vasoconstrictors and then assessment for liver transplant. For intrarenal AKI, there is a role for biopsy. This constitutes about 34%, wherein the most common cause is ATN. And there are other intrinsic nephropathies like glomerulonephritis, vascular disease, interstitial nephritis. So when we have to focus on treating the cause and following the standard of care. Now, this has been discussed earlier also. AKI, how do we define by International Club of Ascites classification of AKI? It divides into stage 1. Stage 1 is further divided into stage 1A and 1B. 1A is where the creatinine is less than 1.5 and 1B is when the creatinine is more than 1.5. Stage 2 is increase in the serum creatinine of more than 2 to 3-fold from the baseline, and stage 3 is increase of serum creatinine more than 3-fold from the baseline, or creatinine of more than 4 milligram per deciliter with an acute increase of more than 0.3 milligram per deciliter, or initiation of renal replacement therapy. Now, how do we majorly differentiate between the pre-renal AKI, ATN, and HRS? So, as we have discussed, the pre-renal AKI will classically respond to fluids with response to IV albumin. Herein, the IVC will be collapsing and less than 2.5 centimeters. And then we talk about urinary sediments. We see granular cast in ATN. And we talked about NGAL, urinary biomarker. NGAL is highly raised in ATN as compared to pre-renal AKI. Now, HRS type 1 and type 2, the nomenclatures has been changed to HRS AKI and HRS non-AKI. HRS AKI is absolute increase of serum creatinine of more than 0.3 milligram within 48 hours, or a percentage increase of more than 50% using the last available value of the patient within last 3 months. And then HRS non-AKI is divided into HRS AKD and HRS CKD. HRS AKD is a GFR of less than 60 mils per minute per 1.73 meter square for less than 3 months. And if we say it HRS CKD, it is GFR of less than 60 for more than 3 months in the absence of other causes. This is the differential diagnosis of AKI and liver failure. The most common, as we have discussed, is pre-renal AKI, ATN. Then others are toxic ATN, wherein the nephrotoxic medications like vancomycin or quinolones can be also contributing to the AKI, wherein we see we go by diagnosis, goes by clinical history and urine microscopy. And the management is conservative, diuretics for the volume overload, and renal replacement therapy as needed. Then is bile cast nephropathy, HRS, AKI. Bile cast nephropathy, we'll see the bilirubin goes to more than 10 milligram per deciliter, and there will be bilirubin cast on urine microscopy. Herein, the management again is liver transplant to decrease the liver bilirubin levels, and diuretics for volume overload and RRT as needed. Then HRS AKI and other goes, like, we'll not go into the details, the cirrhotic cardiomyopathy, the abdominal compartment syndrome, secondary IgA, that is IgA nephropathy, MPGN, acute interstitial nephritis, obstructive uropathy. One of the drugs like midodrine is also causes obstructive uropathy, wherein the treatment is obviously withdrawal of the offending medication and urinary catheterization. Now the point is why the patients have such high mortality in fulminant hepatic failure. Brain edema and intracranial hypertension accounts for more than 75% of the deaths. Other causes are brainstem herniation, sepsis, multi-organ failure, SIRS at presentation is associated with mortality. We can see ammonia levels in liver failure. Ammonia is central in pathogenesis of hepatic encephalopathy. We can very clearly see the correlation of serum ammonia levels with clinical status of hepatic encephalopathy patients. Ammonia levels and also its brain delivery predicts brain swelling and mortality. Here in the Kaplan-Meier curve, we can see the cumulative survival goes down when the ammonia levels are more than 200. Then there is a linear correlation between acute kidney injury and urea clearance. As in the ammonia levels increases, the urea clearance also decreases, and the dose for RRT requirement also goes up. Also, hyponatremia potentiates the ammonia effects on hepatic encephalopathy, hyperammonemia leading to increased intracellular osmolality, leading to water shifts from the extracellular space, and also the hyponatremia acting in the similar way leads to astrocyte dysfunction and further potentiating hepatic encephalopathy. Outcomes of cirrhotic patients with the need for acute RRT. This has been described that the various systems like SOFA score that had the best predictive ability in this population compared to opaque. For the subgroup of patients with AKI, the SOFA score had the best discriminating accuracy, and also the MEL score in the critically ill cirrhotic patients had almost the same discriminative capacity as the SOFA score. Now, also the critical illness score, the CLIF score, the CLIF C calculated 48 hours after starting RRT was the best predictor of mortality in RRT regardless of the liver transplant options. So a CLIF C ACLF score of more than 59.5 could predict ICU mortality with a sensitivity of 83.3% and specificity of 85.7% and could help to identify futility. Here we can clearly see the patients with RRT had a significant higher ICU mortality than patients without. And ICU of 28-day, 90-day and 1-year mortality in patients with RRT was 71%, 83% and 92% respectively, whereas the mortality without RRT was much lower, that is for 4%, 30% and 53% respectively. Now we talk very short about the liver support systems, which constitutes the plasma exchange, the Prometheus system, plasma separation and absorption system, and the Mars. Prometheus is no longer done. It was now the Mars is still followed. How does the MAS act? Molecular adsorbent recirculating system. It removes the albumin bound as well as water soluble toxins. These includes the bilirubin, bile acids, ammonia and other toxic heavy metals, urea and other uremic toxins. The MARS system, herein it gets connected to the CRRT system, wherein additional filter is used for the this clearance of the albumin-bound toxins. This is the Prometheus system, which is no longer followed. Here in the AlbuFlow, there was an additional filter which used to be used, but now it has not been. Now it's not done. Now, coming on to challenges to provide renal replacement therapy in liver failure patients, they are hemodynamically unstable, hemorrhagic tendencies are more, greater ammonia accumulation, increased intracranial pressure, dyselectrolemia, especially hyponatremia, fluid overload, and increased inflammatory cytokines in sepsis. What are the classical indications to initiate renal replacement therapy in liver disease with acute kidney injury? Blood urea level of more than 200 milligram per deciliter, metabolic acidosis with a pH of less than 7.2, hyperkalemia of more than 6 milliequivalents per liter and rapidly rising despite and refractory to medical management. And urea for more than 24 to 48 hours despite high dose furosemide and fluid overload of more than 10% of body weight or organ edema. Plus there are other liver indication which are hepatic encephalopathy with cerebral edema, metabolic acidosis, fluid overload. Now what are the available modalities for RRT for AKI? These are basically divided into intermittent therapies and continuous therapies. Intermittent hemodialysis, and then there is slow low efficiency hemodialysis SLED. Continuous therapies are CVV HT and peritoneal dialysis. Now how do we choosing the kidney replacement therapy modality in patients with liver failure? Clearly, liver failure, acute liver failure or acute on chronic liver failure in patients, hemodynamic unstable, hepatic encephalopathy, CRRT is the first option for them. Patients who are outpatients like chronic liver failure patients who also have hemodynamic instability along with ascites, we see if the patients are hemodynamically stable, we can offer them intermittent hemodialysis along with intermittent paracentesis as and when needed, or peritoneal dialysis. And if the patients are stable and having ascites, we can also offer them peritoneal dialysis. It has advantage of not doing intermittent paracentesis, which can be actually done through the peritoneal dialysis only. Now, comparison of different modalities of RRT. If we compare the blood flows are higher in hemodialysis, ranging from 2 to 300. CRRTs they work in a different way. The blood flows are low. They are ranging between 100 and 150. The dialysate flows are around 500 mils per minute for a hemodialysis, and for CRRT it is 1 to 2.5 mils per minute. Duration, the durations are longer for CRRT like continuous therapies, because they're continuous therapies. CRRT, peritoneal dialysis goes on for more than 24 hours. And the hemodialysis and SLED are intermittent therapies. They go for shorter periods, like 3 to 5 hours for dialysis, and SLED we can extend up to 12 hours. The urea clearance is high in hemodialysis, that is close to 40 liters per session in hemodialysis, and in CRRT is close to similar, around 24 to 60 liters per session. Now choice of modality, CRRT is associated with better hemodynamic stability, slower correction of hyponatremia, and more stability of the intracranial pressure, though the studies have not shown much difference in the survival, incidence, or time to recovery of kidney function. If we look here, we can see the control of uremia toxins in CRRT. There's always, basically in CRRT, it's a continuous therapy. So there is no rebound of these things. But in the therapies like SLED and hemodialysis, there is a rebound of uremia, and there is the larger molecules also, it's a rebound in these therapies. So if we talk about advantages of CRRT, it is obviously has hemodynamic tolerance is better. There is slower corrections of uremia, acidosis and electrolyte disturbance, no significant increase in the intracranial pressure and cerebral perfusion pressure, and adds convection to diffusion to increase the clearance of middle molecules. So if we have these clinical scenarios, how do we go about? The first option for fluid overload or for patients with hemodynamic instability, or if the patient have acute brain injury or intracranial hypertension, we straight away opt for CRRT as a first option. Also here, the paper published at an NDT showed that the hemodynamic stability during CRRT was better. There was lesser fluctuations in the heart rate and systolic blood pressures associated with CRRT. If we see the impact on the pressure reactivity index, intracranial pressure, cerebral perfusion pressure, we see CRRT, the cerebral perfusion pressures are better as compared to hemodialysis. Now seeing the effect on the cardiac index again and cerebral perfusion pressures, patients with CRRT, the cardiac index does not go down and there is lesser fluctuation. Also the cerebral perfusion pressures are better. CRRT maintains ammonia levels without fluctuations. The continuous levels are with CRRTs are lowered as compared to other therapies like intermittent hemodialysis and PD. So why is CRRT preferred in liver failure? It has hemodynamic stability. Changes in osmolality during CRRT are minimal. Slow and sustained correction of uremia, hyponatremia, hyperammonemia, acidosis. It is not associated with increase in the intracranial pressure and reduction in the cerebral perfusion pressure. It can be safely used intraoperatively. Fluid removal is better. It does not require any water treatment facility and it can be done anywhere. So the challenges are with the problems with the volume management can lead to intradialytic hypotension and cardiac events, increased hemorrhagic and prothrombotic risk. There is a lower circuit lifespan, risk of with dyselectrolemias like hyponatremia and hyperammonia. There is a risk of cerebral pontine myelinosis and risk of cerebral edema in acute liver failure patients. So there are few problems with CRRT, like it is expensive, needs trained personnel and dedicated machine, and regional citrate anticoagulation has to be very carefully used as it may cause citrate toxicity. So these were a few studies wherein it was shown that CRRT done on the patients with ALF had a better survival as compared to the no CRRT group. And also there was a study done by Kudoso FS in 2017 which showed that it was associated with the reduction in the 21-day transplant-free mortality as compared to intermittent renal replacement therapy. Also this would this was a very recent in 2024 published meta-analysis and a systemic review which showed that use of CRRT in ALF patients is associated with overall and transplant-free survival as compared to patients who were offered no CRRT. Now coming on to timing of CRRT, when should it be initiated? These are 4 landmark trials, that is the ELAINE, the IKIKI 1 and 2, the IDEAL ICU and the START AKI, wherein unfortunately the liver population was underrepresented. But ELAINE population had few patients with liver failure, wherein it showed there was the patients who were offered early CRRT had a mortality benefit as compared to patients who were given it late. So patients who inevitably need dialysis do not benefit from waiting because of high rate of complications. However, an individualized approach should be used. Patients likely to recover are not subjected to dialysis. But those who are likely to require dialysis, it should be started as soon as possible. So several clinical trials have shown no benefit, but as we have discussed, in recent studies, NGAL has been proposed to correctly assess the difference between ATN and other causes of AKI in the cirrhotic population. Now coming on to fluid management, fluid overload is associated with worse outcomes, and albumin infusions in hypoalbuminic patients could be useful in stable patients to improve fluid removal. Sodium remodeling does not associate with attainment of UF goals, total UF volume or mortality. Tools like BAS ascites is not well detected. RBVM useful in stable chronic patients, evidence conflicting its use in the critical care setting. Now let's talk about CRRT modalities, CRRT modes of therapy. So CRRT modes of therapy are divided into 4, that is SCUF, the slow continuous ultrafiltration, which is primarily removes the patient's fluid. Then continuous veno-venous hemodialysis. Herein there is they act by diffusion, and there's the small molecule clearance, and also the removal of patient's fluid. CVV HDF we are following here. We are doing CVV HDF routinely. Herein it removes by diffusion as well as convection. It removes both the small, middle, and large molecules along with the also the ultrafiltration, the fluid. These are the diagrammatic representation. Ma'am, basically CVVH is not using convection. So if the convection combines with diffusion, it becomes CVV-HDF. So SCUF is, we know we are routinely doing it here. It's a safe fluid removal and ultrafiltration by convection. And CVVH again it works by convection. And CVV-HDF, here we know that we have to give the replacement fluid also. So we can see 3 bags, the dialysate, the effluent, and the replacement. So this works by both the principles, diffusion as well as convection. There is solute removal and safe management of fluid removal. So these are the solutions in different modalities in CRRT, wherein we just saw that replacement fluid has to be used with CVV-HDF and CVV-H. And fluid and solutes both are removed in these modalities. And in SCUF, only there is fluid removal. So dialysate is fluid containing electrolytes and buffer to achieve hemostasis by removing waste balance electrolytes and aimed at normalizing the composition of blood. Used in diffusive modalities for the clearance of small molecules. And replacement is fluid containing electrolytes and buffer, which are actually given to replace the losses of the plasma, water, and electrolytes, which is there by CVVH and CVHDF. It is used in convective modalities for the clearance of both small and medium to large molecules, and it can be infused before or after. So it can be pre-pump or post-pump, both. It can act as a diluent if given pre-filter. Now the anticoagulation, it is given to maintain the patency of the CRRT circuit. It helps to extend the filter life, and it preserves the filter performance. It minimizes the blood loss as a result of clotting. Maximize continuity of care by helping to reduce the treatment downtime. So anticoagulation could be systemic, both patient and circuit are anticoagulated, or it could be regional, whereas only the extracorporeal circuit is anticoagulated. So anticoagulation, if we say, anticoagulation in CRRT is used to prevent the filter blockade. And 3 modalities are available for no anticoagulation. Then there is systemic anticoagulations, typically with heparin, which cannot be used in the liver failure patients. And then there's RCA. RCA, if all of them are contraindicated, then prostacyclin can also be used as an alternative. So if we talk about RCA, it is recommended by KDIGO guideline as the first anticoagulant choice. If no contraindications exist. It has the highest patency, filter patency, lower risk of bleeding, but it requires rigorous protocols. So if we see, we can see how it works. It is basically a calcium-free dialysate. The citrate chelates chelates the free ionized calcium, and it returns the blood. Returning blood combines with the venous blood in the body, normalizing the ionic calcium and preventing the systemic anticoagulation. Herein, the calcium has to be infused through a separate central line to replace the calcium lost in the ultrafiltrate. So, but here the problem is that in liver failure patients, there is a lack of hepatic clearance, which leads to increased circulating calcium citrate complex, leading to citrate toxicity. So, there are certain measures how it can be mitigated. This risk can be mitigated by using lower blood flow rate along with lowest dose of citrate needed to maintain a therapeutic post-filter calcium, and by increasing the effluent rate if needed to augment the citrate removal. So there were certain studies, one came in 2017, wherein long-term CRRT and anticoagulation with citrate in critically ill patients with severe liver dysfunction was possible. Findings indicated that probably extrahepatic metabolism citrates also seems to exist, avoiding in most cases citrate accumulation in critically ill patients. Then there was a paper published in 2023 in Frontiers, wherein regional RCA can be effective and safe in liver failure extracorporeal organ support. Close monitoring and timely adjusting during the process could reduce the risk of complications. The advantages were there was no risk of citrate accumulation, no difference in the pH, serum lactate, ionic calcium between liver and non-liver, and circuit life was better. Then CVV-HD, this was a paper published in Critical Care with regional RCA in patients with liver failure, wherein they had seen patients with a higher lactates and prothrombin time of less than 26% before the onset can predict an increase in this with a higher sensitivity and specificity. So patients who are more sicker should not be offered RCA, or it should be very carefully done. This is one we have collected the data. This was a retrospective data collection which was done, wherein the study populations were divided into no heparin and RCAs, given RCA. Herein we used RCA at a very low dose, which was 3 millimoles, and it was safe. There was no additional metabolic complications or mortality risk associated with RCA. Also, there was no significant improvement. There was a significant improvement in the filter lifespan, which prompts its consideration in this high-risk group of patients. But I think randomized RCTs are needed to actually confirm this finding. So this we can see pre-post CRRT RCA, the lactates were not different. If we look at the mortality, there was no difference in the mortality. But there were, if we look at the filter clotting was significantly lower in the RCA group, thus reducing the downtime of this. Now coming on to cessation of CRRT, how do we decide that we have to stop the CRRT? Urine output at the time of cessation of CRRT was the most important predictor of successful weaning. Diuretic usage negatively affected the predictive ability of the urine output. 24-hour creatinine clearance within 24 is one of the predictor of how we can go about deciding to stop the CRRT. Anticoagulation we have talked about. Now very briefly about hemodialysis. It has challenges. So, but patients who can be transitioned from CKRT to IHD, the challenges being managing the anticoagulation, hemodynamic inability to remove the ascitic fluid, and also need for intermittent paracentesis, bleeding at the site of catheter insertion, prolonged bleeding after needle removal. So, oral midodrine, low dialysate temperature, and IV albumin could potentially help prevent hypotension during dialysis. PD has successfully been used for patients who have compensated cirrhosis. It also offers an additional advantage of draining the ascitic fluid and provision of caloric load. But it has its own challenges like increased risk of peritonitis, increased loss of protein via the PD fluid. This peritoneal dialysis is feasible as a bridge to combine.
So we have questions on CRTs. I think we should stick to CRT.
Conclusion, choice of CRRT is based on patient characteristics, CRRT is preferred in hemodynamic instability, increased intracranial pressure, high ammonia, marked fluid overload, and liver failure. CRRT is not associated with increase in the intracranial pressure, slow and sustained correction of azotemia, hyponatremia, hyperammonemia, and acidosis, which makes it an ideal mode for RRT in liver failure. CRRT can be used intraoperatively to tide over the uremic crisis such as acidosis and hyperkalemia. Circuit lifespan is not much different in liver failure than other acute kidney injury, and RCA may be used closely monitoring for citrate toxicity, and it is useful as a bridge for liver transplant in end-stage liver failure and should be available in. So what about SLED? It is an hybrid technique that has advantages compared with both CRRT and IHD, and therefore in critically ill patients it could be used as a bridge technique between CRRT and IHD. Hemodialysis complemented with intermittent remains the modality of choice. Obviously we've discussed it in the stable patients. PD has been used successfully in patients with compensated cirrhosis. Albumin dialysis could be life-saving procedure for a carefully selected subgroup of patients in liver failure. Thank you.
Thank you, Chan.